Now back to health and wellness correspondent Lee Kelso.
And we are rolling on here with HealthCall Live Radio Hour. Our second half hour features not only Greg Russell, the pharmacist and nutritionist from the Fort Wayne Custom RX, but also we're jumping out to California and rejoining Dr. Cedric Jamie Rutland, a pulmonary and critical care physician, also a national spokesperson for the American Lung Association. Jamie, you're just coming off rotation in the ICU. That's what I understand. Tell me how your night went.
The night was, a little bit congested, a little bit busy because, what's happening is as a result of all of these patients that end up being COVID positive or patients that we're ruling out for COVID, you still have your routine ICU patients, your routine critical care pulmonary consults that need care. And so the beds are being congested by these patients that are in severe respiratory failure secondary to SARS-CoV-2. And so what ends up happening is you just have a lot of patients that you are caring for and really trying to understand the details of, so that way you can set forward the appropriate plan so patients can improve.
Mm-hmm. A lot going on for you. The FDA just shifted the status of hydroxychloroquine to expanded access. So that means now you can use it. Do you have access to that drug, and how would you anticipate using it?
So we're using it right now as we speak. We do have access to that drug. And now what is happening and what we're doing is patients that we presume have SARS-CoV-2 and COVID-19, the disease that SARS-CoV-2 causes, we are immediately putting them on hydroxychloroquine. And the doses that we're using is 400 BID for a couple of days and then 400 daily. But we're immediately putting them on hydroxychloroquine, and then we determine if tocilizumab is necessary, which is an interleukin-6 inhibitor, and we start to apply for compassionate use of remdesivir as well. So we have a couple of patients on both, and so that's how we're using that therapy.
When you go through that process of getting the passionate use, how long does it take for you to typically get the drug?
Oh, man, it's taken some time because I think Gilead is overwhelmed with the request of compassionate use. So it's taken probably up to 48 hours, sometimes even 72.
And what kind of effect are you seeing with these meds on your patients?
It varies. I think one of the things that we do in medicine is we try to come up with objective findings before we initiate therapy. And so what ends up happening when we all do that is we're all a little bit different. And so if you initiate medicine, I think, early enough, you would think it's going to have a positive effect on people. And for some people, it works and people improve clinically. But for some people, that pathologic process, that cytokine storm, the process that the disease puts the body through is so far down the line that you're not going to get that reversal that you would hope to get when you initiated the medicine.
So they're just already too far down the road in their disease process for it to have the effect that you're hoping for.
Yeah, some are too far down the road, some are not, and some improve. But you can't really say, is this the medicine or is this just the natural course of this person's disease? Every person genetically is different. Right. We're almost in this time of, I hate to say it, but we're almost in this time of survival of the fittest. The people who don't mount this significant immune response to this virus are the people who improve.
Are the patients in your care the typical profile? Are they aged and with comorbidities, other illnesses?
The patients who are severe fit that typical profile. They are the ones with comorbidities, and they are the ones that are aged, right? They're the ones that are 60, 65, above that age. But I have seen some that are younger with the virus. And no, their symptoms aren't as severe, and they're not in the intensive care unit, but they do have the virus.
Sure.
So when you have a patient who is really having a tough struggle here, we keep hearing about respirators. Will you tell us more about how they work and what those things are doing for us?
The respirators, the ventilators?
Yeah.
Okay, so here's how a ventilator works, and I was actually asked by some of my medicine colleagues to do a crash course since they all have to learn it these days. So what a ventilator does is it provides your lung with oxygen, and it provides your diaphragm relief of work. So typically speaking, when you take a deep breath in, your diaphragm, which resides inferior to your lungs, contracts down, and it allows air to enter by reducing the pressure in your lung, making it lower than the atmospheric pressure, so air can come into your lung and you can perform gas exchange. What ends up happening when you develop severe infections, whether it be pneumonia, whether secondary to bacteria, or pneumonia secondary to SARS-CoV-2, the immune system starts to infiltrate the balloons, right? So your alveoli are basically a bunch of balloons that are normally full of air. But when these balloons fill up with white blood cells and other molecules and fluid comes with these white blood cells in these balloons, your body has a difficult time gas exchanging, and you have a difficult time taking a deep breath, and it requires an enormous amount of work on the patient's part to take that deep breath. And so what we do is we take away that work and allow the patient to rest and put them on a ventilator. So a ventilator in of itself is not therapeutic. It is a means of support to help the patient get through this difficult time if they can get through the difficult time.
So in other words, the ventilator is not doing anything to cure the disease. It's just keeping the patient alive until the body can kind of manage that virus to its end state.
Yeah, correct. And even, sorry, go ahead.
No, you go ahead.
Even with the ventilator, in the process of doing that, remember what I had just explained to you. I had explained to you the diaphragm, upon contraction, initiates a negative pressure in the lung, sort of like a vacuum, so air just kind of sucks into your lung. That's a negative pressure. What the ventilator gives us is a positive pressure, which can result in injury to the airways, thus increasing the amount of inflammation in the airways, and thus perpetuating that inflammatory response, which can become a problem.
Yeah, that's called, you're talking about the tidal volume of the respirator. So think about the air flowing in and out of the lungs as kind of like the tide coming in and going out in the ocean. And so you have to carefully manage the pressure and the volume of air that you're putting in there so you're not damaging the tissues, right? So
just enough air.
Yes, you're exactly right. And that's something where, as an intensivist, we get asked about that all night, right? We're measuring certain pressures of the airway, and the respiratory therapist will say to me, hey, this guy's airway pressure is 40, and I have to figure out a way to get that airway pressure lower, or I have to say to myself, is this just a natural part of what his body is going through, and I got to deal with that high pressure because the lung is full of gunk, right? When the lung is full of gunk, as you can imagine, there's not as much air sacs there to receive the air, so that pressure can go up pretty high.
You're listening to Health Call Live, your regular Saturday morning appointment with healthcare professionals, where treatment is always painless and there's never a copay. Here's your host, health and wellness correspondent Lee Kelso.
And we are back with Dr. Cedric Jamie Rutland, a pulmonary and critical care physician in practice in California. Also with us here in the studio is Greg Russell, pharmacist and clinical nutritionist from Fort Wayne Custom RX. And we're going to get you on the air. Tim, our listener question. Go right ahead, Tim.
Can you hear me?
Yes, sir.
Okay, quick question and then a quick comment. I am reading online that the coronavirus does not like high alkalinity. We know that Walmart did, when they had it, sell alkaline water. You can buy pitchers where you put your water in and it becomes alkaline. I have read that at 6.0, which I apologize, I don't know if that's base or neutral, or 6.0, the virus replicates very well. At 7, it does a little worse, and at 8, if you can get your alkalinity up at 8, it will stop replication. Grandma used to give me baking soda in a glass of warm water. Do you know anything about that? And also, we have had an FDA and a CDC that don't really seem to be helping the people. We have had a CDC that was worried about gun control and stuff like that. And if they were doing the job that we pay them for, we might be in a better shape shape, so I will take the answer off the air. Thank you very much.
Hey, thanks for your patience, Tim, while we got you on. Greg, you want to add to the alkalinity question?
Yeah, alkalinity is quite an interesting. A lot of people try to use a lot of alkalinity to supposedly help take inflammation down, et cetera, et cetera. I have some problems with alkalinity because you need stomach acid in the first place to help digest foods. So people consume too much of it, it can actually make them sick. However, we also know, coming back down to the hydroxychloroquine, quinine type family of drugs. They put quinine in water to help with alkalinity, so there may be some truth to it, but again, who knows, right? So I would just be cautious if I drank a lot of alkaline water.
Dr. Rutland, do you want to chime in on that one?
Hey, Tim, you bring up a couple of excellent points. The first point that you bring up is one of alkalinity. Now, what we do know, at least for hydroxychloroquine, is we do know that there was a study published in the Cell by Liu and colleagues just recently. And what the study showed from an in vitro standpoint, that's in the Petri dish, is we noticed that hydroxychloroquine, not only did it not allow the SARS-CoV-2 to enter the cell, but because of raising the pH of the environment from about 4.5 to 6.5, so more alkaline, that virus was not able to bind to the cell. The spike protein was not able to bind to the cell as well. Mm-hmm. So there is some truth to what you're saying in alkalinity in terms of infection of the virus. So that's a good point. Your second point of the CDC, listen, everybody is trying to help us. We're the physicians out there putting ourselves in this environment that's dangerous for us, and we understand what everybody is saying. It's not like the people, the government aren't trying to help us. They're trying to make sure we have supplies. They're trying to support us in every way that we can. And I think it's not a good time to criticize organizations that are trying to help us because maybe of past mistakes or past misgivings. It does not matter. It's all about what happens now, how we're changing and how we're moving forward for the better of the environment for the physicians and for the patients.
So, Dr. Rutland, we had you on the program about 2 weeks ago. I am shocked at the acceleration in this pace. How is it affecting you?
It's an interesting time. It's a historical time. I think the way that I like to think about it is like this. This is a very unnatural moment in our lifetime, but it is a very natural moment in history. So when you think about pandemics over the course of time, they happen. Viruses can do this, bacteria can do this, and they get to a certain point in their evolution where this kind of thing can happen. And what it does is it just creates a congestion on the healthcare system. Yeah. So our caseload has gone up significantly, right? We're at about 20,000 cases in the United States. In California, it keeps going up every day. And so we're feeling this congestion as physicians. Is it changing how we practice? Not necessarily. It's just that we've got our ICUs and our critical care units a lot more full than we're used to seeing. But it has drastically changed over the course of 2 weeks, and I think it's going to continue to drastically change. This is not a week-by-week thing. This is a 12 to 18-month change and a 12 to 18-month different world for us in the hospital.
How are your team members managing all of this? So my understanding is, in a lot of ICUs, they're in PPE for 6 to 8 hours at a shot because, A, you don't want to waste this stuff by putting it on and taking it off. And then your point of exposure is when you're removing that equipment after you've been around these patients.
Yeah, that's a great question. I actually have two of my teammates in the office with me right now. And, we're holding up. We're managing the process well. And what we try to do is reduce our exposure time. So we only go into the patient's room when it's absolutely necessary. And we try to make it so one doctor goes in the patient's room a day. You don't need 15 doctors to go in the patient's room every day because that is going to, one, use supplies, and two, increase the time of exposure for physicians opening and closing that door. Mm-hmm. So we're getting better at organizing that process. But I think, we're holding up. There's people that are afraid and people that are scared of getting the disease. And then there's people like me who think, gosh, I probably already had the disease. We just got to keep going as long as I'm not demonstrating symptoms.
Are you testing? Are you testing yourselves and your other team members?
We only test if we have symptoms. That is dry cough, fever, dyspnea, which is shortness of breath. Those are the only times we're really testing. There are institutions that I know of in which physicians do have the virus and are pretty asymptomatic.
Interesting. The California now is in a total lockdown, right? You guys are not supposed to be out traveling. What's happening? Give me a sense of how that feels on the ground.
Well, I mean, for me, it's really no different, right? I still get up every day.
Well, yeah, you're exempt, right? Yeah. But what do you see around you?
From that. But around me, what I see is my kids are in the house. They're not going to school. They're picking up computers from school, which is nice to be able to learn things and to continue schooling. But it's just quiet. The neighborhoods are quiet. The roads are quiet. The Starbucks line is still long, though. But
carry out's good, huh?
It's just really quiet on the outside, and it's necessary. Sometimes I do get a little frustrated when I see 19 to 29-year-old kids trying to congregate together, but it's just a quiet scene, and people think it's going to be a short time, and it's not. It's going to be a long time.
Tell me about that. We've got a minute and a half left. I'm going to give that to you. Tell me what you think is coming.
So you're going to see an increased rate of cases. You're going to see more cases. Hospitals are going to be more burdened by the presence of these cases, and we're going to be forced with making very difficult decisions. We're going to have to train nurses who are not used to taking care of critically ill patients. We're going to have to train them critical care on the fly. Physicians that are not trained in critical care, but that are subspecialists, are going to need to be trained in critical care. So it's going to be a community that evolves, so to speak. There's going to be a lot of physicians out there who aren't used to managing these patients. They're going to have to get used to managing these patients. And in terms of the world and the civilian population, they're going to have to get used to being inside, because that's where they're going to be for a while. Everything's going to change. School's going to be from home, so on and so forth.
Are you at capacity at your hospital? Are we looking at tents in the parking lot anytime soon?
We are not at capacity, but we're getting there. We're not quite at capacity, though.
Well, I can't thank you enough for taking the time. I know you're just coming off shift. Thank you very much for being with us, and I hope we can check in with you in a couple of weeks. And if something pops and you need to reach out to us, please don't be shy about that, will you?
Hey, I won't. Hey, thanks a lot, you guys. Sorry for talking so much, Greg. I apologize.
That's okay. I found what you said very encouraging and horrifying at the same time.
Yeah,
I think for us that live here in Indiana, we're wondering what our next step is going to be when we may be going to this so-called social isolation.
And we have to make our next step out the door. Time is gone. We'll see you next week on Healthcare Live.
You've been listening to HealthCall Live. Watch a recording of today's program on the HealthCall Facebook page or on the web at www.healthcall.live. Drop us a line to recommend a guest or suggest a topic for a future broadcast. Join us next Saturday at 9 a.m. for another edition of HealthCall Live on WOWO 1190 AM and 107.5 FM.